Good evening. My name is Melissa Chang. I'm a colon and rectal surgeon at St. Joseph Mercy Ann Arbor Hospital in Michigan. I would like to thank the program chairs, Dr. El-Saidi and Dr. Tellem, as well as the session chairs, Dr. Whiteford and Dr. Lee, for the opportunity to be presenting on laparoscopic resection of T4 tumors. I apologize in advance for not being able to be there with you all in Las Vegas. I have no disclosures. Minimally invasive surgery has been associated with improved perioperative outcomes in countless studies over the last 30 years, revealing early return of bowel function, shorter hospitalization, fewer VTE complications, fewer pulmonary complications, reduced wound complications, and less postoperative pain. However, 15% of colon cancers are locally advanced on presentation. So despite the benefits of minimally invasive surgery and colon resection, is laparoscopic resection of locally advanced colon cancer oncologically safe? As this may necessitate en bloc resection, this is an important question to consider. There have been large randomized controlled trials that have studied minimally invasive surgery versus open in colon resections, where T4 tumors were part of the exclusion criteria. In the Barcelona single institution study in 2002, as well as the COST study in 2004. And in fact, in the COLOR study, multi-institutional study, they found a conversion rate of 50% for T4 tumors, and therefore a minimally invasive approach was not recommended for these tumors. Similarly, the quality of life study from 2018, LCASE, also excluded T4 tumors as part of their study. The MRC Classic trial did not exclude T4 tumors, and they found that locally advanced tumors were more likely to require unplanned conversion. In these patients, there was increased complication rate as well as decreased overall survival. However, in the discussion and review of their 3-year and 5-year follow-up, they felt that it was the disease process rather than the conversion itself that led to poor outcomes in these patients. There has been to date no randomized study between open versus laparoscopic resection. And the current data has been limited to observational cohort studies. In these systematic reviews and meta-analyses performed in the last 5 years, they found no difference in overall survival, no difference in disease-free survival, and an oncologically feasible approach where no difference in resection margin was found with adequate lymph node retrieval. The conversion was required in 20% of attempted laparoscopy for T4 tumors. And knowing that T4B tumors are not similar in T4A tumors in terms of the surgical complexity, as well as poor 5-year disease-free survival and overall survival, subgroup analysis found no difference in overall survival in T4B tumors in the open versus minimally invasive approach. In a more recent study published this year, this was a study with the National Cancer Database, including nearly 22,000 T4 colon cancer patients treated between 2010 and 2014, where over 1/3 of these patients were treated with a minimally invasive approach, including both laparoscopy as well as robotics. The conversion was slightly higher at 22%. However, they revealed an improved survival in minimally invasive surgery, even when adjusted for potential confounders, including patient demographics, as well as comorbidity score, as well as tumor characteristics, including size, lymph node status, and whether or not patients went on to be treated with chemotherapy. Clinical diagnosis of T4 is challenging, preoperatively. The sensitivity of CT detecting accurate depth of invasion is 70%, and accuracy of overall preoperative CT staging of T4 is 75%. Preoperatively diagnosed locally advanced T4B tumors may be preferentially selected for open resections, and pathologic T4 diagnoses may reflect easier resections. And so therefore, some of the studies and data presented to us may be skewed based on surgeon and patient selection. T4B, however, is not a contraindication for laparoscopy. It is rather the nature of adjacent organ involvement that necessitates conversion. Organs such as the bladder, the adnexa or uterus, and the small bowel are feasible to be performed in a minimally invasive approach. And anecdotally, well described in case reports, duodenal involvement has been described as a restriction for a minimally invasive surgery. And therefore, based on all of the literature and what we know, is that the benefit of laparoscopy is clear in these patients. However, ANSAGES and ASCRS consensus guidelines recommend a minimally invasive approach when feasible. However, we must tread with caution with T4B tumors, as en bloc resection is dependent on the structure involved as well as the surgeon's skill and experience. It's important to consider that depending on the T4B multivisceral involvement, oncologic resection may not be feasible despite approach used, whether open or minimally invasive. Prospective studies on T4B tumors to determine precise selection criteria are still needed. And the studies have reflected that with appropriate preoperative patient selection, attempt at minimally invasive surgery is not detrimental, even if conversion is needed. Thank you all for your attention. And again, sorry I can't be there with you in Vegas. My contact is as follows.